functions of the liver. So as you know that the liver is the largest organ in the body, composed of two main lobes, the right and the left lobe. And histologically, it is composed of many cells, and lobules are considered the functional unit of the liver. Lobules contain many important cells, important of which are hepatocytes, stellate cells, and Kupffer cells, in addition to sinusoidal epithelial cells. Also, the liver contains cholangiocytes, which are the biliary tract epithelial cells. The major functions of the liver include formation of plasma proteins, including albumin and globulins, in addition to formation of coagulation factors and formation of endogenous cholesterol, as well as bile salts. Also, liver play a vital role in conjugation of bilirubin, in addition to metabolism of carbohydrate, proteins, and lipids. Also, the liver play a crucial role in detoxification of some toxins like ammonia, and also elimination and excretion of many medications, besides excretion of bilirubin. Also, liver is act as store for many essential vitamins, especially the fat-soluble vitamins and vitamin B12. Also, the liver play an important role in immunity, especially by production of immunoglobulins and by containing macrophages in a form of Kupffer cells. Okay, next slide. By definition, liver function tests are the collection of non-invasive biochemical tests that can help us to determine to assess the function of the liver. And they are commonly requested in clinical practice, liver function tests, and considered one of the basic and routine laboratory studies that should be done every now and then as in patients or outpatients settings. So the ability to interpret liver function test or the skills of interpretation of liver function test is mandatory for practicing physicians as well as for medical students. Okay, next slide. So the main indications for requesting or for ordering a liver function test can be requested as routine medical checkup, or if there is suspicion of a liver disease, especially for those who present with jaundice, and also for monitoring liver disease. And also, it is essential to request liver function test before commencing any hepatotoxic medications. Good example for this, before using anti-tuberculous medications. As you know that the majority of first-line anti-TB medications are hepatotoxic. So before commencing, for example, anti-TB medication, it is mandatory to perform baseline liver function test. And also pre-operative evaluation. It's important because some drugs used for conduction or induction of anesthesia, like halothane, also can cause hepatotoxicity. So these are among the common indications for doing or performing liver function test. Okay. So important components of liver function tests include liver enzymes, a form of ALT, AST, and alkaline phosphatase, GGT, and 5-nucleotidase, and also assessing the total bilirubin in the form of conjugated and unconjugated bilirubin, and assessing total protein, including albumin and globulins, and also prothrombin time or INR. Yes? So this table showing the reference range of the important elements of liver function test. When interpreting a liver function test, you should strict to the reference range provided by the lab, which performs the test. So it is mandatory to depend on that because there are some variations between there are variations in lab regarding reference range in many lab studies, including liver function test. Okay. So broadly, to assess liver function test, they are classified into tests that can help us to assess the synthetic function of the liver. This include observing or analyzing total bilirubin, albumin, and prothrombin time. Tests that can determine hepatocyte injury, important of which are the ALT and AST enzymes. And tests that can detect any biliary inflammation, injury, or obstruction. And these are reflected by the alkaline phosphatase, GGT, and 5-nucleotidase. Yes. So markers of liver synthetic function, including bilirubin. And as you know that bilirubin is the byproduct of hemoglobin breakdown, especially the heme part of the hemoglobin. Total bilirubin include conjugated and unconjugated bilirubin. And bilirubin can be measured in milligrams per deciliter or by micromole per liter. So in terms of milligram per deciliter, it is ranging from 0.2 up to 1 milligram. It's considered normal. Regarding micromole per liter, up to 17, between 3 to 17 micromole per liter is considered normal. Normal situation, unconjugated bilirubin constitute about 80% of the total bilirubin. Jaundice expected to occur if bilirubin exceed 2.5 milligram or 34 micromole per liter. So in such situation, jaundice can appear clinically. According to the underlying cause of jaundice, the jaundice is classified into prehepatic, hepatic, or hepatocellular, or cholestatic. Prehepatic jaundice is commonly result from excessive or excess breakdown of hemoglobin, as seen in hemolysis, or can be due to failure of conjugation of bilirubin, like some inherited conditions like Gilbert syndrome can lead to prehepatic jaundice and other syndromes. But cellular jaundice is the type of jaundice that occur due to either acute or chronic liver, having acute or chronic liver insults. And in this type of jaundice, both types of bilirubin will be elevated, conjugated and unconjugated. But usually conjugated bilirubin in such situation will be dominant. Cholestatic jaundice is the type of jaundice that results from biliary inflammation, injury, or obstruction. These pathological insults can occur inside the liver, intrahepatic, or outside the liver. So in such situation, the conjugated bilirubin will be highly elevated in cholestatic jaundice. So when interpreting liver function test, if liver function test showed only elevation of unconjugated bilirubin, we have to consider important differentials, including hemolysis or Gilbert syndrome, and rarely irregular Najjar syndrome. So in such situation, we have to assess the patient further for the elements or features of hemolysis, including CBC, peripheral blood film, observing for reticulocyte count, LDH, and haptoglobin. So having low hemoglobin, high reticulocyte count, high LDH enzyme, and low haptoglobin in someone with unconjugated hyperbilirubinemia. This is consistent with hemolytic cause, like hemolytic anemia or any other conditions that can lead to hemolysis. So if the patient is having high unconjugated hyperbilirubinemia without evidence of hemolysis, so in such situation, we have to consider the Gilbert syndrome or the Crigler-Najjar syndrome. So in terms of prevalence, Gilbert syndrome is more commoner than Crigler-Najjar syndrome, and usually it can lead to mild jaundice. Can lead to mild recurrent attacks of jaundice, especially when exposed to infections or stressful situation. While Crigler-Najjar syndrome, especially type 2, which is mainly seen in adults, because type 1 Crigler-Najjar syndrome is usually occur earlier during infancy period. So this syndrome is severe, can lead to severe jaundice and complications, such as neurological complications. So clinical phenotype and genetic studies can help to differentiate between Gilbert syndrome and Crigler-Najjar syndrome. Yes, go ahead. Another important element that can help us to assess the liver synthetic function is the measurement of serum albumin. Albumin is mainly formed by the liver, and normally it's range from 3.5 up to 5 gram per deciliter, or you can say 35 to 50 gram per liter. Liver disease, especially chronic liver disease, is a common cause of albumin reduction, hypoalbuminemia. But however, low albumin is not specific for chronic liver disease. It can be caused by many other conditions, especially chronic kidney disease, nephrotic syndrome, malnutrition, malabsorption, and protein losing enteropathy. So if the patient is having low albumin and high INR, this is suggests liver disease. But if the patient is having only low albumin with normal prothrombin time, this can suggest non-hepatic cause of low albumin. Another important protein that is formed by the liver are the globulins. A normal globulins level is ranging from 2.5 up to 3.5. Liver form alpha and beta globulins and also gamma globulins. Important gamma globulins that can be associated with some liver disease include IgG. High IgG titer is seen in patients with autoimmune hepatitis, while high IgA is seen among patients with alcoholic liver disease. High IgM seen in patients with primary biliary cholangitis. Next. Reverse albumin to globulin ratio. Albumin normal situation are abundant. The level of albumin are more than globulins. If this ratio is reversed, this can suggest presence of hypergamma globulinemia, like situation seen in those who have autoimmune hepatitis because of excess level of IgG, or in patients with primary biliary cholangitis because of presence of high IgM. And explanation for this hyperglobulinemia, because this is a compensatory mechanism done by the liver due to lack or production of albumin level. Yes. Another important synthetic element of the liver function test include prothrombin time, or INR. And prothrombin time is usually decreased in chronic liver disease, especially when the liver loses about 80% of its normal reserve capacity. So also prothrombin time can be prolonged in patients with acute liver failure. So this is a good indicator or a good marker or pointer to presence of acute liver failure, which is a serious complication that can be seen in some patients who present with acute hepatitis, viral hepatitis, autoimmune hepatitis, or drug-induced hepatitis. So all these group of patients, they are liable to develop acute liver failure. So any patient with acute features, once he develop prolongation of prothrombin time or elevation of INR, we have to suspect acute liver failure. Other causes of high INR include vitamin K deficiency, use of warfarin or other anticoagulants, and development of DIC, disseminated intravascular coagulopathy. As I mentioned before, having prolonged prothrombin time and low albumin, this is typical for chronic liver disease. Important elements or markers that can point to hepatocellular injury, inflammation, or damage include alanine aminotransaminase and aspartate aminotransaminase. And both these enzymes are called transaminases. And these enzymes are released from the hepatic cells or hepatocytes. Having elevation of ALT and AST is called transaminitis. In normal situation, ALT is usually ALT is considered more liver specific than AST, because ALT is mainly found in liver tissues, while AST, besides found in the liver tissues, also can be present in other organs, includes the cardiac and skeletal muscles, the kidneys, brain, and red blood cells. So if your function test showed marked or high elevation of transaminases, elevation of 10 to 15-fold from the upper limit of normal, is highly, that is to say, from 500 to thousands of international units per liter. This is typically seen in patients with acute viral hepatitis, autoimmune hepatitis, ischemic hepatitis, and drug and toxin-induced hepatitis. While having massive elevation of transaminases, elevation more than 10,000 international units per liter, this is a rare manifestation, but usually point to a severe liver injury, conditions that causes extensive hepatic injury or necrosis. And this is usually seen in those who have acute liver failure and ischemic hepatitis. Modest elevation of transaminases, having elevation around 400 or less than 400 international units per liter. This is typically seen in alcoholic hepatitis. While mild elevation of transaminases, this is commonly seen in those who have fatty liver disease, chronic hepatitis, and liver cirrhosis. Normally, ALT is higher than AST. So having a reversed AST-ALT ratio, this is can suggest presence of cirrhosis. And this is commonly seen in patients with liver cirrhosis, irrespective to the underlying cause of liver cirrhosis, especially if the AST-ALT ratio of 1. While having AST-ALT ratio of 2 or more, this is typical for alcoholic hepatitis. AST-ALT ratio of 4 or more is reported in patients presented with acute Wilson disease, acute fulminant Wilson disease. As you know, that Wilson disease is inherited metabolic liver disease, can take different presentation, can present acutely with acute hepatitis, sometimes can present with acute liver failure. And also it can present in chronic state. Also, AST can be higher than ALT in those who have muscle disorders, such as dermatomyositis or rhabdomyolysis. As I said before, AST also can be released from skeletal muscles, from the heart and other tissues other than the liver. Clear? Shall I continue? Okay. Markers of biliary disorders or biliary disease include alkaline phosphatase, gamma glutamine transpeptidase or transferase, and 5-nucleotidase. These enzymes merely release from the cholangiocytes. So excess level of these enzymes, especially if occur together, can suggest presence of biliary inflammation, biliary injury, destruction, or obstruction. Yes. Commonly performed enzyme among these biliary enzyme or cholestatic enzyme include alkaline phosphatase. Normally, it is range from 40 to 120 to 125 units per liter. Beside the production from liver, also alkaline phosphatase can be produced by bone disorders, especially from a bone osteoblast. Other sources include the placenta, especially during pregnancy, kidneys, intestine, and white blood cells. High elevation of alkaline phosphatase can suggest presence of cholestasis or cholestatic disease or infiltrative disease. While mild elevation of alkaline phosphatase can be seen in patients with viral hepatitis, autoimmune hepatitis, and hepatocellular carcinoma, as well as alcoholic hepatitis. Gamma glutamyl transferase or transpeptidase, or both terms are correct, is another enzyme that can suggest a biliary disease. But it's not also specific to the liver disease, also can result, elevation of GET can result from alcohol, chronic alcoholism or chronic alcohol intake, prostate cancer also, ischemic heart disease, and some drugs like phenytoin also can result in elevation of GET. But having elevation of GET and alkaline phosphatase is significant, usually indicate liver disease. But having only elevation of GET with normal alkaline phosphatase, this increased suspicion of non-hepatic cause of GET elevation. So how to differentiate between hepatocellular and cholestatic injury? So in this situation, we have to compare the level of ALT and alkaline phosphatase. So if there is tenfold from the upper limit of normal increase in alkaline phosphatase, and less than threefold increase in alkaline, more than tenfold increase in ALT, and less than threefold increase in alkaline phosphatase, this suggests a hepatocellular disorder or defect or injury. If the reverse is true, that means having less than tenfold increase in ALT and more than threefold increase in alkaline phosphatase, suggests cholestasis. Cholestasis, that means there is something disrupting the bile flow because of inflammation, destruction, or restriction. Can you mention some conditions that causes intrahepatic cholestasis? Anyone? Anyone can answer this question through chat? Intrahepatic causes of cholestasis. Yes? Important causes of intrahepatic cholestasis include drugs. Some drugs can cause this, like oral contraceptive pills, and also primary biliary cholangitis, primary sclerosing cholangitis, and intrahepatic cholestasis of pregnancy. So all these examples for conditions that causes intrahepatic cholestasis. Extrahepatic cholestasis commonly caused by obstructing insults like gallstones, including the common bile duct, tumors like cholangiocarcinoma, carcinoma of the head of the pancreas, and also primary sclerosing cholangitis can involve the intra as well as the extrahepatic biliary ducts. In some situation, we can have elevation of both of transaminases and alkaline phosphatase, because some condition can cause both, can cause hepatocellular injury at the same time can lead to cholestasis. So having high elevation of transaminases of ALT And alkaline phosphatase, this can suggest having hepatocellular as well as cholestatic injury. Yes. So to know that whether the alkaline phosphatase is due to if there is high elevation of alkaline phosphatase in liver function, to determine or differentiate between liver cause and non-hepatic causes, you have to observe the GGT, the other cholestatic enzymes, the GGT and the 5-nucleotidase. If there is elevation of alkaline phosphatase and GGT, this highly suggests presence of cholestatic disease or biliary disease. While having high elevation of alkaline phosphatase with the normal other cholestatic enzymes, that means normal GGT and 5-nucleotidase, this highly suggests non-hepatic cause of elevation of alkaline phosphatase, like bone disease, like pregnancy. Which bone disease that can commonly lead to elevation of alkaline phosphatase? This is another question. Which bone disease? Yes, very good. Multiple myeloma and osteomalacia. Yes. Yes. So liver diseases are, according to the type of injury or pathology, are categorized into 3 main types: the hepatocellular. Good examples include hepatitis, different types of hepatitis, acute or chronic hepatitis, steatosis, fatty liver, cirrhosis, and hepatocellular carcinoma. So all these good examples for conditions that causes hepatocellular inflammation or injury. Infiltrative are conditions that characterized by having granulomas, like sarcoidosis, tuberculosis, and liver metastasis. So cholestatic are conditions that can affect the bile ducts, as I said before, either inside the liver or outside the liver. Yes. Having elevation of ALT and AST transaminases is highly suggestive of hepatocellular injury with normal or mildly elevation of alkaline phosphatase. If the reverse is true, that means having high elevation of alkaline phosphatase and other cholestatic enzymes with normal or mild elevation of transaminases is typically seen in cholestatic condition and in infiltrative diseases. So alkaline phosphatase is elevated in cholestatic conditions and in infiltrative conditions. Transaminases are highly elevated in acute hepatocellular if there is a condition causes acute hepatocellular damage, like acute viral hepatitis, autoimmune hepatitis, or drug-induced hepatitis. While in chronic hepatocellular damage or chronic hepatocellular disease, the level of ALT either normal or mildly elevated, will be either normal or mildly elevated. In cholestasis, the same also, the ALT or transaminases in general, either normal or mildly elevated. Regarding cholestatic enzymes, ALT, alkaline phosphatase, and GGT, and in acute hepatocellular injury, they are either normal or mildly elevated. The same thing in chronic hepatocellular injury, either normal or mildly elevated, while in cholestatic or infiltrative disease, they are highly elevated, alkaline phosphatase and GGT. Total bilirubin in acute hepatocellular injury, either mildly elevated or highly elevated. Chronic, either normal or mildly elevated, while will be highly elevated in cholestatic conditions. So this table can summarize some points discussed previously during our discussion. So if the patient is having abnormality in liver function test, so after interpretation, suggestion of a possible diagnosis, the next step, we have to investigate to look for the underlying cause of the liver disease. So commonly, we perform serology for viral hepatitis, especially for hepatitis A, B, and C, and other non-viral hepatitis, if serology for the classical viral hepatitis is negative. And also, we have to screen for autoimmune hepatitis by searching for autoantibodies like ANA, anti-smooth muscle antibodies, anti-mitochondria, anti-neutrophil cytoplasmic antibodies. And also, we have to measure the immunoglobulins, IgM, IgG. And if all tests for all these mentioned causes are negative, we have to investigate for the rare diseases like Wilson disease. Have to do serum copper and serum ceruloplasmin and ion studies to rule out any hemochromatosis, and alpha-1 antitrypsin level to rule out any alpha-1 antitrypsin deficiency, especially if the patient is having if there is family history of liver disease, because Wilson disease, hemochromatosis, and alpha-1 antitrypsin deficiency are inherited conditions. So all these sort of investigations, we call them liver screen. So the main purpose is to look for the underlying cause of the abnormality in liver function test. And of course, we have to integrate the history with physical examination findings, okay, as we routinely do in our clinical practice. So first of all, we should obtain history, then we should conduct physical examination, and then we have to do liver function tests, biochemical investigation, then we can proceed to do more sophisticated investigations in order to reach a likely diagnosis. And also ultrasound, abdominal ultrasound, also essential investigation, especially if liver function tests point to presence of biliary disease. Ultrasounds, and also we can do further, can go for MRCP and ERCP, MRCP or ERCP, especially in also in cholestatic manifestation or cholestatic pattern of liver function test. Yes. So now we have some cases, okay, so as to consolidate what we have learned. So in the first case, 28-year-old male presented with jaundice for 2 weeks. Past medical history unremarkable. So this is the only information provided from the history of this patient. So we have to rely on his lab data in order to in order to consider a likely diagnosis. So his lab studies showed hemoglobin of 15.2 normal. So CBC normal, including hemoglobin, white blood cells, and platelets. His liver function test showed high total bilirubin. It's almost 357. ALT is 1,307. AST also 1,100 units per liter. Alkaline phosphatase is 220, while albumin is 3.7 gram per deciliter. Prothrombin time, 53.8, that is to say an INR of 4. So can you suggest a likely diagnosis? So from this, are we dealing with acute or chronic liver disease? What do you think? Acute. What support acute liver disease? Acute for sure, yes. What supports that? Very good. You are absolutely right. Duration, excellent. Duration of his symptoms. Duration of his jaundice, just 2 weeks. Second thing from lab studies that support acute insult. High elevation of transaminases. Again, this is a feature of acute rather than chronic. Very good, yes. Third thing, albumin. Yes, albumin is within normal. So how to explain prolongation of prothrombin time? Why this patient is having high INR? Severe elevation of INR. It's almost 4. Yes. Yes. The possible explanation for this high INR or marked elevation of prothrombin time is due to acute liver failure. So in someone with features of acute hepatitis, once you find a high INR, you should consider acute diagnosis of acute liver failure. This is a very serious condition. If not treated properly, can account for high mortality rate. Okay. So can you suggest 3 likely causes for this acute liver failure? So acute viral hepatitis, very good. Acute viral hepatitis, possible cause for acute liver failure here, yes. Drugs also, yes. Which drug that can lead to acute liver failure? Excellent. Paracetamol overdose, yes. Acetaminophen or paracetamol overdose is a common cause of acute liver failure. Yes. Third differential. Autoimmune hepatitis. Very good. Autoimmune hepatitis is another important condition that can lead to this clinical and biochemical scenario. Fourth differential. If this patient gave a family history of liver disease, Wilson disease. Yes. Go ahead. Next slide. So a liver function test obtained from a patient showed total bilirubin of 3 milligram elevated, conjugated bilirubin of only 0.2 milligram. Liver enzymes, including ALT, AST, and LDH, all are normal. Serum albumin within normal, and normal INR. His complete blood count, hemoglobin, white blood cells, platelets, and reticulocytes counts are normal. So what is the most likely explanation for the disturbance of liver function test in this case? This liver function test obtained from a patient who present with recurrent attack of jaundice. Why pancreatic? So unlikely, nothing to support pancreatic. Or you said prehepatic, sorry, prehepatic. So this patient is having high unconjugated bilirubin. So this patient is having prehepatic cause of jaundice. Very good, yes. Because of high unconjugated so liver function test in this patient showed only elevation in unconjugated bilirubin with normal other elements of liver function test. So in this situation, you have to think of prehepatic cause. Common prehepatic cause include hemolysis. Hemolysis is excluded here because no evidence of hemolysis. Hemoglobin normal, reticulocyte count, and LDH also normal. So the most likely diagnosis will be Gilbert syndrome or Crigler-Najjar syndrome. But the commonest one is the Gilbert syndrome. So most likely Gilbert syndrome in this case because of recurrent and mild attacks of jaundice. So most likely Gilbert syndrome. Third case, this liver function test obtained from a patient, 45 years old female, who present with jaundice. Her liver function test showed high total bilirubin, which is of 6 milligram per deciliter. She has high ALT, mild elevation of transaminases, ALT and AST, and high elevation of alkaline phosphatase and GGT, while her total proteins are 8 grams per deciliter. Her albumin is 2.5. IgM is elevated and of a high titer. Her serum cholesterol is high. So what's your comment on her total proteins and albumin? Someone to comment on total proteins and albumin? So total proteins, 8 grams, while albumin is only 2.5. So that means there is reverse albumin globulin ratio. So globulins are higher than the albumin. This is because this patient is having high IgM, immunoglobulins. So the correct diagnosis or the most likely diagnosis, integrating her clinical scenario with biochemical abnormality evident by liver function test. Yes. So autoimmune disease, primary, yes, primary biliary cholangitis, not sclerosis, primary biliary cholangitis, because this she is a female and typical age for primary biliary cholangitis. She's having cholestatic pattern on her liver function test, evident by high elevation in alkaline phosphatase and GGT. And also, this lady is having a high IgM. This is typically seen in primary biliary cholangitis. And also, she has high serum cholesterol. So what is the explanation for high serum cholesterol in this case? Why she has high hyperlipidemia or hypercholesterolemia? Yes. In normal situation, endogenous cholesterol mainly normally excreted through the bile, okay? Because of bile biliary duct destruction, this lead to accumulation of cholesterol in the blood because of failure of excretion, yes. Which autoantibody is specific? Further investigation be done for this patient to confirm your clinical suspicion of primary biliary cholangitis. Further lab test, important lab test. Yes, you have to assess or you have to screen for anti-mitochondrial antibodies. Presence of these autoantibodies of a high titer will be diagnostic for this condition, for primary biliary cholangitis. At the same time, also we can do anti-neutrophil cytoplasmic antibodies to exclude primary sclerosing cholangitis. So you have to do AMA and anti-neutrophil cytoplasmic antibodies. Yes. So liver function test obtained from a patient showed the high total bilirubin, an ALT of 150 units per liter, AST of 300 units per liter, and albumin, normal serum albumin, and high GGT of 300 units per liter, and normal alkaline phosphatase, and normal INR. So I would like someone to comment on GGT and alkaline phosphatase. Yeah. So which one is high? GGT is high, while alkaline phosphatase. GGT high, while alkaline phosphatase is within normal limits. So this indicates what? Hepatic or non-hepatic? That means, sorry, not hepatic, cholestatic or non-cholestatic cause. That means biliary or non-biliary disease. So highly suggestive of non-biliary disease, non-biliary. If biliary, alkaline phosphatase will be elevated as well, okay? So having a high GGT and normal alkaline phosphatase, this highly suggestive of non-biliary disease. So this patient is having high GGT, high transaminases, and AST is higher than ALT. If you calculated the AST-ALT ratio, it is 2. So what is your clinical diagnosis? If you are allowed to ask this patient one question regarding his history, which question? Yes, very good. You should ask him about alcohol consumption or alcohol use. So this is typical liver function. These findings are typical for alcoholic hepatitis. High total bilirubin, high AST-ALT ratio, is typically 2, and high GGT. So these findings are consistent with alcoholic hepatitis. Yes, go ahead. Another liver function test revealed high total bilirubin and mild elevation in transaminases. However, AST is a little bit more than ALT, which is unusual, and low albumin. Albumin is only 2 grams per deciliter, and normal alkaline phosphatase and high INR. This patient is having high INR of 2.3. Normally, INR should be less than 1.3 or less than 1.5. So are we dealing with acute or chronic liver disease in this? These results suggest acute or chronic. Excellent. So these results are typically indicate chronic insult. What support chronicity here in this liver function test? Yes, low albumin and high INR and mild elevation in transaminases. So all these findings are typical for chronic liver disease. So all these findings are typically seen in liver cirrhosis. So these findings are consistent with liver cirrhosis. Last case. 20-year-old woman presents with abdominal distension. Her blood test reveals the following: low hemoglobin, she has mild anemia, high MCV, so it is macrocytic anemia. White blood cells are within normal, while platelets are mildly reduced. She has a mild thrombocytopenia. Her total bilirubin is normal, within normal. ALT also normal, but alkaline phosphatase is high, 450 international units per liter. GGT normal. So someone to comment on alkaline phosphatase and GGT. What do you think? Alkaline phosphatase in these results obtained from this lady showed high alkaline phosphatase with normal GGT. So whenever you find high alkaline phosphatase with normal GGT, you should think of non-hepatic cause. Okay. Although this patient is having other features that might suggest liver disease, like thrombocytopenia and low albumin. Okay. So albumin in this patient is low as well. So it's not written here, but also this lady, she is having low albumin and thrombocytopenia. So what is the most likely diagnosis? And she is presenting with abdominal distension. So abdominal distension, it might suggest presence of ascites. Someone who has anemia and thrombocytopenia and low albumin. So what could be the diagnosis here? Thalassemia? Very good. These findings are typically indicating pregnancy. So this lady is having pregnancy. Because pregnancy can lead to macrocytic anemia and also can lead to low albumin. The low albumin in pregnancy due to it is dilutional because of high blood volume. The same thing applied for thrombocytopenia. Pregnant ladies, they can have thrombocytopenia because dilutional thrombocytopenia. So the most important pointer to non-liver disease is the elevation of alkaline phosphatase with normal GGT. So this lady is having pregnancy. She is presenting with abdominal distension and she has amenorrhea. So now we reach the end of this lecture today, workshop. So you should remember that liver function tests are very essential laboratory studies that every now and then are performed to the patients. Sometimes ALT can appear before development of clinical features. On the other hand, also normal liver function tests do not always indicate an absence of liver disease. Also, you should consider this in mind. And also having abnormal liver function tests not always indicate liver disease, like the scenario seen in the last case. An important thing also, or message you should convey is that liver function tests should always be interpreted using reference range from the lab that performs the test. Okay? Because there are variation in reference range of liver function tests from lab to another. So you should interpret liver function tests based on your lab guidelines. Any questions? If no questions, I will. السلام عليكم ورحمة الله. شكرا لحضوركم واستماعكم ومشاركتكم يعني.
شكرا لك دكتور عروة برضو إنك قبلت الدعوة وعلى تقديم الشرح الأكثر من رائع. يعطيك العافية.
الله يسلمكم بالتوفيق إن شاء الله. شكرا.
شكرا.
الله يسلمك.
برسل رابط التحضير الآن، راح يكون متوفر ل10 دقائق وبعدين راح نقفل السيشن.